All right, hello. So next up we have a panel discussion during which an incredible group of individuals is going to discuss peer recovery services. And we're thrilled to have the panel moderated by Dr. Hulsey. So Dr. Hulsey serves as the Senior Technical Advisor of Drug Use and Epidemiology and Data with Vital Strategies Overdose Prevention Program. In his role, he supports governmental and community stakeholders to use data and evaluation to inform action. Prior to his role, he managed behavioral health analytics for Allegheny County, Pennsylvania, where he led a team of analysts to ensure the appropriate design and quality of health-related data in the county's integrated data warehouse, designed and led analyses for internal and external audiences, and advanced the adoption of advanced analytic and data visualization tools. He has nearly 20 years of experience in health and human services, including clinical services, health analytics, information systems, public policy, and quality improvement. His expertise lies in evidence-based substance use disorder care and system design, and he's worked in overdose prevention for most of his career. While trained as an evaluator, he is a former clinician, and these technical efforts have remained conscious over the perspective of direct service providers and the people they serve. Over the past few years, he's also been passionately involved in the ED-MOUD initiative, and he's advised on its development, evaluation, and improvement. And he helps lead the initiative's evaluation efforts in partnership with Johns Hopkins Bloomberg School of Public Health. So I'll turn it over to Eric.
Thank you. Does the sound okay? Can't quite tell. All right. Well, I'm very grateful to be here today, and I felt privileged with my colleague Julie from Vital Strategies, having partnered with CFSEM and MOP for over 3 years. Early 2020 is when I came on, but it's really exceptional to see all the work that you all have done just over these past few years, and just to see some things that were concepts coming into reality. It's a really privilege to witness that here in Michigan. I'm based in Pittsburgh. Go Steelers. But I think, our panel today, I think you're going to hear from all of these experts in the different roles and the organizations, how they do this work. You're going to see that there's more than one way to kind of deliver peer services. And I think, you can take that for what you will, but each system that you're in, your unique context, I think there'll be more than one nugget that you can take from this discussion. And each of these folks has plenty of experience, so if you're interested in some dimension of that, before the end of the day, chat them up. What are peer services? I think there's conventional understanding of these that they'll help people move in this context that we're talking today, moving from the emergency department to some community, whether that be treatment, recovery community organization. But just a few core components of peer services. They sort of help they're designed and delivered by people with lived experience and have been successful in the recovery process. They help people begin or remain engaged in a sort of successful recovery, or whatever their life choice might be for how they like to live. And I think an important thing too is that while they're non-clinical, these are professional services. And I think you'll sort of start to see that from when you hear the experience of my panelists this morning. But before we start, maybe we could start with Sandy. If you could just take a minute to talk about who you are, your role in the organization you work with. Go down the line.
Yeah, I'm Sandy Arnold from Detroit. I work for Sobriety House in partnership with DMC. I'm in long-term recovery, 20 years plus years in recovery. Just here to try to let people know that recovery is real, recovery is achievable, possible.
Yep, and I'm Jake Manteuffel. I'm a ED staff doc at Henry Ford, Maine. I'm also boarded in addiction medicine just recently. I made up a title of Director of Public Health, and I applied for that job. I got it, but it's really a honor and a privilege to sit next to Sandy and the whole team here, because people like Sandy are the ones that actually give me passion for this work. That you've been through something and you can relate to the patient way better than I can, or a nurse can, or even a social worker can. And I truly believe that there is tremendous value, not only financially, but just in people and care of patients. So yeah.
Hi, my name is Frankee Walker. I am the peer recovery coach supervisor for Families Against Narcotics. We provide community-based peer services throughout the state of Michigan. We currently have 40 peer recovery coaches, and we serve about 800 people at any given time with peer recovery coaching services. And our peer coaching program feeds most of our other programs, in the sense that when someone comes to one of our other programs, they are offered a peer recovery coach. So,
Hi everyone, my name is Dunya Barash. I am also from Families Against Narcotics. I'm the Director of Operations. Really privileged and thankful for this opportunity to be able to talk to you guys today. Frankee shared a little bit about what we do with peer recovery coaching at FAN, but one of the things that we also try and do in the community is really engage health professionals in the work that we're doing, and being able to dig into the stigma that comes with substance use disorder and just some of the frustrations of navigating this tough system, being able to be a helping hand. And we do that across the state of Michigan and are able to connect people and families to services. One of the things that I think is really special, and I like to mention in front of a room of healthcare professionals, is I'm a family member of a person that was impacted by substance use disorder. I'm a social worker too. But the way that my father found recovery was through his primary care doctor. And I think that a lot of times doctors don't get enough credit for the work that they do in this space.
And I'm Erin McClelland, and I'm the Director of Clinical Services at New Path in Genesee County. And we're a large treatment center who works primarily with men and women, adults, men and women, who present oftentimes with co-occurring disorders. And we have a very large team of peer recovery coaches, and the actual program I'll be talking about today during the questions is our opioid overdose recovery program that we've been doing since 2018, I think midway of 2018, working with the 3 area hospitals in Genesee County, having peer coaches go in, provide services, and link and coordinate and navigate, which we're going to get into more. But that'll be the primary program, but there's a whole bunch of things that New Path does that I'm also happy to share with if that opportunity comes about.
Erin knows the questions that are coming. So maybe we can just pivot back to you and just allow you to continue to describe the wide range, how New Paths has employed peer recovery support services.
Sure, I'd love to. So I think we have close to 20 peer recovery coaches on staff. 22, thank you, peer recovery coach supervisor, who's joined us today. 22, I mean, it is remarkable. And I really consider them a bridge, glue, a star I plucked from the sky, whatever it is, that the work that they do in the program is beyond anything I've ever witnessed. My background is in counseling, and I'll admit when we were introduced to peer recovery coaches, I'm like, I don't know what to do with them. I only know how to work with counselors or therapists, social workers. And eventually we just learn, right? We learn together, we learn what this role looks like, had to put the right people in place, the right dynamics. So when we were approached by Region 10 PIHP, which is the Genesee County PIHP, to have this service where we're able to provide peer recovery coaches in the hospital, it made perfect sense because New Path had already had a contract going back, I think a decade before that, maybe a little less, with the hospitals and our sobering facility. So we're very unique in the sense that we have a sobering facility where individuals can come into that don't have to be insured, that don't even have to be from our county. And trust me, we get them from everywhere across the state of Michigan. And it just made sense. Hospitals were familiar with us, we're familiar with them. Let's go bring peer recovery coaches bedside. And it was the perfect opportunity because many of the individuals we were working with that would come into treatment were telling us not so great of stories about their experiences in the emergency departments. And I completely understand it because it doesn't mean it doesn't happen in residential treatment when you hear they're back again, here they are, you didn't get it this time. So it wasn't just a hospital or medical-based setting, it was just kind of the world we were living in at that time. So we were able to utilize the recovery coaches to meet individuals bedside in the event of an overdose, intoxication, withdrawal, whatever that may be that the individual was going through. And it ended up advancing more than just opioid use disorder. So we're able to meet them bedside for any substance they may present in the emergency department, which then led us to our partnerships with law enforcement, which also now we are meeting people in the jail where they are for justice-involved individuals. So it just continues to grow to be able to meet the needs of individuals where they are.
Great, thank you. Would Van like to take that?
Absolutely. So many of you might know Families Against Narcotics for our original program we started in 2017 called Hope Not Handcuffs. Hope Not Handcuffs was really created in a time of emergency. We were seeing overdoses starting to increase in our community and families just not really knowing where to go. We had an opportunity to really talk to the community and figure out what are the spaces that are available for folks to be able to go into and have the safe community space. And so we identified that police departments would be a space that is across communities where folks could enter and be able to go up to the front desk and ask for help. And from that, we were able to really look and measure and figure out what are some other services that folks need besides just getting into treatment. From that opportunity, we identified that, okay, we were getting people into treatment and people were starting to get better. Resources were becoming a little bit easier to navigate, but we didn't know what happened to them after that point. So we started to connect folks with peer recovery coaches and offering every single person that walked into their police department an opportunity to link up with a peer recovery coach and also a family coach. From that program blossomed a program called Hope and Healing, which is a partnership with health systems that are interested in offering services similar to offering the services that FAN offers inside of their health system. And that really started because of Tiffany back there. She was a champion in being able to offer services to folks that come into the emergency room and either face an overdose or any number of substance use disorders and getting them connected to services. And from that, original program, we've been able to partner with several different health systems to offer similar things that really meet the need of that health system. So some health systems are able to navigate and be able to help connect patients to services, where others really need, maybe don't have the staff identified that can do that. And so we have a Hope line that is answered from 8 a.m. to 10 p.m. We field about 1,000 calls a month, and that number can be given out to patients across the state of Michigan to help with being able to connect to services. And at that point, we also offer peer recovery coaching and family coaching to those folks as well. We have a number of other services as well. We have combat quick response teams across the state of Michigan, which is really similar to what she just talked about, partnership between law enforcement, peer recovery coach, and a family coach, where we're going out and responding to those overdoses that are happening in the community and offering people services. And many times you will interact with those same people as well. So it's good to know the combat quick response teams that are in your community, because you can always connect with them and come up with different solutions for that team to be integrated into your health system as well. We have a harm reduction program, which is growing. Currently, we are located in McClelland County for our harm reduction services, where we give out safe use supplies, naloxone, fentanyl test kits, really anything that a person would need if they're still actively using drugs. And that is another service that we offer up for folks that are inside health systems to be able to call us and utilize those resources. Just a quick plug, because I think it's important. We do have a table back there where folks can access naloxone today. We also have the Narcan boxes. If any of you have clinics where you'd like for Narcan to be placed, we have the ability to do that across the state of Michigan. So our team is over there. And I guess I'm sure that more will come out, so I don't want to take up all the time, but I'll let Frankee go next and talk more about our peer recovery coaching.
Thank you. Yeah. I think it's that.
Pass that to him, maybe.
So one of the things that came out of our peer recovery coaching program also is our scholarship program, which I think is really important to mention, where we, like Dunya was mentioning, excuse me, when people come out of treatment, what is happening to them? And so we are able to connect them with 2 weeks of funding for a recovery house or a sober living, as a lot of people know it. So I think that that's important to mention. But one of the things that we've done with healthcare, because I definitely want to talk about this because I think it's very important. We've partnered with Corewell mostly, some Henry Ford, but with Corewell, their addiction doctor, Dr. Chimami, has residents that come in and work under him, and they are all required to take an SUD round. And so what happens during that SUD round is that they have to come out and shadow with one of our peer recovery coaches for a full day. So they actually go out into the community and work with a peer recovery coach and see firsthand how those services impact the individual that we're serving. And every resident that's come through has said that this is the best part of their SUD round. They've gone into methadone clinics, they've gone into treatment centers. There's a whole plethora of things that they have to do during this time. And they always say that that was the best part of the SUD round, actually getting to see firsthand what kind of services and the relationship that peer coaches build in the community with the people that they're serving. Because although we all want the same thing for these individuals, the one thing that's missing when it comes to medical things along those lines is the identification. Peer recovery coaches are all people in recovery. They can sit down and really have a conversation about where you are and having had that experience. And this is what I did when I was going through this, and how hard it is. I don't know that anyone who's not in recovery can really say firsthand, or excuse me, I'm sorry, can really say what it's like to experience that. And so having that identification and that bond is really the most important, and that's why it's called peer, because it's peer to peer. Like, I'm up here dressed today in a blazer and slacks. I don't do that when I'm meeting someone in the community. I'm dressed probably the way they're dressed, and I try to speak in the language that they're speaking, right? I don't go in with a high vocabulary, throwing words at them that maybe they don't understand. And, through phone calls and, early introductions to people, we find out where they are, right? We see where they are vocabulary-wise. We see where they are economically. We see where they are as far as being unhoused or having, a supportive family, or not having anyone. And so really identifying those things up front is what makes this relationship so important. And knowing that, not that long ago, I've been in recovery now for 9 years, not that long ago to me, I was exactly where they are, right? And the empathy and the compassion and the love that comes from that is not something that, if you haven't experienced it, that you can share with someone. And so, FAN is very fortunate in the sense that our coaches are strictly community-based, and so they are out in the community. They're able to transport. They connect them to the barriers of recovery. We ask them, what does recovery look like to you? What is in the way of that happening? And so we provide those resources. We're able to take them to the resources that we're connecting them with. We're able to sit with them through phone calls that might be frustrating, and setting appointments and getting them. Sometimes it might be grocery shopping, right? Someone doesn't have transportation, taking a bus to a grocery store and coming home with 10 grocery bags. That's a barrier, right, to feeling just human. And so, we're able to do all of those things in the community. We recognize that this isn't an office-based practice. None of the people that we serve with coaching services actually come to our office and sit with peer recovery coaches. We meet them wherever they are in the community, and we meet them wherever they are in their recovery journey. So that is really the part of peer coaching that makes it unique to any other service that's provided.
Great, thank you. Dr. Manteuffel, you want to talk about how your organization uses these services?
Sure. So I also going to make up a job title called Director of Public Health for the System, because that's also what I do now. So I have a little bit of a unique perspective on this. We have hospital-employed peer recovery coaches at Henry Ford, Maine, and we decided to use that model. I blame Dr. Khaldun, who has gone on to fame since then, but she was part of our public health committee back in 2019 when we were 18 and 19 when we were exploring how we were going to implement an OUD program. And she brought in a group from her Baltimore roots called Mosaic, and they helped us set up our program, which it is very unique compared to others and unique compared to what else we have going on in the system. So I'll talk a little bit about that, but we also are partnered with FAN for some of our sites just in the last year, and we're hoping to increase our numbers as we screen more patients in triage. And then we also work through local PIHPs as well. I think Jackson site is about to sign up with Homa New Vision to have an in-house peer. Macomb has been well partnered with CARE, and Wyandotte is now about to start with Higuera. So that's really 3 different models, and to some extent, you know, at Maine campus, I do like the way we have it set up. The problem is they're hospital employees and they are not funded through the PIHPs, and so it leaves me in search of a Band-Aid for funding for them. Although I have some commitment from our leadership that will keep them on. But that's what keeps me up paranoid at night, thinking that some of these coaches that I've grown to love, you know, could ever be in a bad situation. So that is not something that, you know, that's something that keeps me up at night. And I know I've begged several people in this room for funding, so thank you for your support in the past. And I've identified some new targets going forward. But I think what makes our at the main campus unique is the integration that they have with our team. They are essentially kind of on their own. We can call them to see a patient, but every patient, you know, most places have triage-based screening, but every patient that comes in, you know, they're asked about substance use questions if they're obviously intoxicated or in an overdose situation. Essentially, they're flagged. They get a red check in a box as opposed to a green check, and then your green check can turn to a red check if you later on in the patient encounter, you disclose some substance use, and especially if you're looking for help. So all these red checked patients actually filter onto, we use Epic, the Epic track board, and the peer coaches, when they come in 7 days a week, just log in and they have a work list essentially. And we had to remove marijuana as a drug, a substance based on essentially clogging up the track board. And so mostly this is opioid patients. Those are the highest priority. Anybody with an overdose, opioid overdose is highest priority. You know, second priority would be somebody in withdrawal. Opioid withdrawal, and then alcohol is right up there too as well, but they do prioritize opioid patients first. And they will go and see them. The exceptions would be if they have an acute psychiatric complaint. So if they're in a psychiatric area, they won't approach the patient, but they will approach on their own essentially, and they make those connections. And I would say about half the patients that we see and treat for OUD come in saying, hey, I would like some treatment, or they're there for an obvious overdose. But I would say another half of them are people that are there for something else but have disclosed opioid use. And so we're getting a lot more touches in those circumstances. And I think over the course of the first 8 months of this year, we had 1,100 peer encounters, and 120 of those or so were declines. And I count those as victories as well, because all those interventions, that is step one into kind of breaking down the stigma barriers that we have, and that patients are approached by a professional person, and asked about their use, in a non-judgmental way, and it lets them know, and Stan, our peer coach, would say, I gave him my card, today's not his day, but we planted the seed. And so I like to count those as, positive successes in some circumstances. So that was in about 8 months, 1,100 patient touches in the first part of 2023. So that's the way I think that we can increase the patient touches. And from there, when the original question back when Dr. Khaldun was helping, was not the medicine. We can teach the docs the medicine. It's not hard, you know, it's easy medicine, but it's where do the patients go from here? And the peers are absolute experts and are relied upon by us to make that connection, and it is complicated. And if you asked a doc to do this, I guarantee you we would not have any type of successful program, and I don't know of any across the country that would ask the doc to find out what's their county of residence, what's their insurance, and that's what's one of the nice things about being an ER doc is we don't have to do the insurance or the check or the wallet biopsy, we see everybody and treat everyone, and we rely on peer recovery to make those connections. And it's complicated, and there's been patients from out of state, there's patients that are uninsured. These guys take care of it for us, and they're absolutely an essential component to our ED now, and they have immense value, you know, in multiple different facets, as I mentioned. So that's the model we use at Henry Ford, Maine, at some of our other freestanding EDs, so we have 10 in total. We use the Hope Line essentially, and that is like our model, and based off of a limited conversation, you know, they're not calling all that much right now, but we have limited numbers there, and we're not fully implemented in our triage screening. I've got a reminder annoyance to make sure the nurses do the screening, just to increase the amount of screening that we do to get those touches, and then when we do get those positives, that nurses and the docs are both on board to reach out to the resources and make sure they get connected to care. And I'm less familiar with the more standard model, which is the PIHP model, but at Wyandotte, Jackson, and Macomb, we do have, there are embedded peers there, and each process is a little bit different, and kind of my role has been, you know, working with the organizations to define that process and have it, you know, easy on the docs, and that's always my pitch line is, you know, we got to make this easy for the docs, because if it's not, we're going to miss the opportunity to engage. So that's what I try to do with a lot of our projects is let's make it as easy as possible, and then it's an easier sell in terms of this uptake of, you know, treating these patients. You know, your patient that came in with you know, opioid use disorder and vomiting and abdominal pain, you know, you didn't have to keep them in the ED for 6 hours and do a CT scan. You know, if you did the history that, you know, revealed their OUD, they're just in withdrawal. They needed a dose of Suboxone or buprenorphine, you know, and if you give them that and give them 45 minutes, they're probably going to be shaking your hand, you know, in some cases, and you know, that's another thing that ED docs like. You know, we like throughput. You know, we went in this because we have short attention spans. You know, we want things to move, and you know, that's another opportunity, you know, to get clinician buy-in. And one of the tactics, I guess, I employ to get some docs that, you know, frankly aren't comfortable with it. You know, either it's, you know, they're afraid we're going to quote unquote attract the heroin addicts to the ED is one of the barriers that. You know, and that's really not been the case. I remember hearing that argument back in 2017 at one of our national meetings, and the East Coast and the West Coast were pretty well represented in saying that having OUD programs in the ED is, you know, this is the way to go, and that was, you know, as early as 2017, the outcry was, no, we don't want that, that would be terrible, and California and some of the East Coast, New York, were kind of testifying that that's not the case, and it's actually one of the most rewarding clinical experiences you can have. You know, you take somebody that feels terrible, that's in withdrawal, you give them medication that they feel better, you know, relatively quickly, and then, you know, long term you potentially change the course of their life. So to me, it's really rewarding medicine. And Eric, I told you to rein me in if I get too tangential here.
I think we might jump off of something that you said on these different models that you have at different hospitals. But I think, Cindy, giving you an opportunity to talk about how your organization has deployed peer services, and then we'll look under the hood on how you all are making this actually happen. But please.
Well, you know, I used to think getting clean was the most beautiful thing in the world, but helping other people get clean is even more phenomenal. And being put in a don't have a proper place to be discharged, they end up back in the ER 24 hours later. And so when the hospital and the doctors see the value of recovery coaches, we're now on the cutting edge of recovery. And families are being reunited. Even the ER nurses and doctors are saying, hey, can you talk to our loved ones? Because they see the value. And a recovery coach is only valuable as his network, you know, because a lot of times the different barriers that happens in the hospital when a person insurance is in McClelland County or Oakland County, I can call on family development, I can call on Narcotics Anonymous for families against narcotics, hope not handcuffs, and they'll provide a ride for that person to get to whatever county that they need to get to. So that's just the partnership and the collaboration with other organizations. And then now we're in the mood of now producing a new breed of doctors that are sensitive to recovery, and that recovery is possible. So I'm just excited about being here. You put so much helium in my head. I didn't know what to do. I thought I was going to float off this seat. But when the doctors see the value of recovery coaches and the nurses get on board, families are reconnected, people are get into recovery, and just the love, just a little bit of love can go a long way, a kind word, you know, because the stigma, self-image, fear, and image, you know, if I tell you who I really am, you may reject me, you know, and then I'm trying to be somebody that I'm not. I'm trying to be intelligent, but recovery is not about intelligence, it's about helping people that want to learn, you know. So thank you again.
Thank you for that. From each of your perspectives, I mean, you're coming from a hospital system, community orgs, community treatment orgs. From your perspective, how do peers contribute? What is that value they contribute to a person's recovery process? You know, let's say if they were to go through licensed substance use treatment or had an emergency encounter without the the benefit of encountering a peer. Would you like to sort of take that one? What value is a peer service or recovery coach adding to that person's experience?
The value is that we've been there and we understand, you know, the difficulties, and failure is not failure. We encourage people to continue to try, you know, motivational interviewing. We talk about what they are doing right opposed to what they're doing wrong. You know, hey, you did come to the hospital, you did ask for help, you know, before you stayed out there 17 months. So that's good. I see a change in you. You know, that encouragement and just love. You can't help the people if you don't love the people, because they interviewing you just like you interviewing them. They know. It's just something about the spirit. It knows if somebody is there for a paycheck or you're just sitting there to really help them. And just that vibe, that energy, that love will open up doors that never been able to open before, you know. And, you know, I had a patient that was saturated in urine, and he smelled so bad, not even the humiliation of the administration saying he smelled, but all he needed was a shower. And I took him back and gave him a shower. And as I gave him a shower and stripped his clothes off, he told me the reason why he was urinating is because he didn't have enough strength to get to the bathroom. And I rolled him back in and challenged the doctor, and they got him in the physical rehabilitation center. In about a month and a half, I'm coming down the ER, and it's, hey, Sandy. And it's this guy that I helped. And he said, I can walk. And I said, well, show me. He stuttered a little bit, but he's now back in his own apartment, and he's on his own pay right now, doing well. But it's because of the collaborations between the two agencies. So
I heard, oh, go ahead.
the encouragement, the love, you know, the purpose. When a recovery coach has a purpose, I have a purpose. My name is Sandy Arnold, but my purpose is to help people that are underserved, that underserved population. That's my purpose, and that makes all the difference.
So I just heard championing, encouragement, love, those kind of things. Somebody who's like looking for that person, you know, you see, and I heard dignity, human dignity in there. So,
Still people.
yeah. Would Ken like to take that? The
Sure,
value?
absolutely. Well, the value, one of the major values that I, as a coach, experienced and that I continue to see the coaches experience with the people they work with is self-direction, right? And how long has it been since someone actually asked that person what they wanted, right? Most people, including the doctors, are telling them, you've got to stop using drugs. Their parents are telling them, you've got to stop using drugs. You've got to get a job. You know, you've got to. And, you know, one of the major roles of a peer recovery coach is saying, what does recovery look like to you, right? What does your life look like? And how can I help you get there? Everyone's been telling them what they need to do for so long, right? But having someone ask you what you want to do and how we can help you get there, to them is like somebody, you know, actually wants to help me do it and not just tell me how to do it. And then I think the other part is the judgment-free side of it. Because whether someone who's in active use is actually being judged or not, you know, whether the doctor's judging them or nurses are judged, they always feel judged, right? Because of the guilt that goes along with drug use. And so having someone who's been where you are and saying, listen, this is judgment-free, right? Like, even if you return to use, if that wasn't your goal and you return to use, don't stop communicating with me, because I already know why you return to use. I'm not gonna ask you why, right? Because everyone's like, why did you do that? Why, you know? We don't really ask that question. We're like, where do you want to go from here? What didn't we address that we needed to address last time? And so I think that that's a huge part of it. And just being a person who suffers from substance use disorder, like, lots of people wanted to help me, right? But until I connected with other people who had navigated this disease, didn't continue to use drugs, and lived productive lives, I didn't care what other people had to say, because they didn't know how I felt. You know, that's how I felt. I'm not saying that that's the truth, but that's how we feel. You cannot understand the hamster wheel that goes through my head, is what I used to tell people. Yes, you might have gone to medical school and you might understand the frontal and the cortex and all these different parts of the brain, but you don't understand how my brain works, right? And how I have a million thoughts all at the same time, all unanswered, all unaddressed. And that's what addiction does to us. And so having someone who can say, listen, I get it, like, and I'm not judging you, and all I want to do is help you make the right decisions for your life, and making them accountable for the resources we provide them, right? So if I give you 3 resources, I'm going to ask you, okay, did you call those individuals? Do you need any support while you're calling those people? We make them responsible for their own self. You know?
And I mean, what I'm hearing there too, yeah, you said it in so many words, but that hope is real. I mean, they're witnessing, like you said, I've been there, you know, and that they're witnessing what the future possibility could be by having that person encounter them.
And we're truth tellers. You know, we really tell them, you know, we don't, and I think Sandy will attest this, we don't go in there and go, oh, recovery's going to be easy. This was such an easy journey for me. You know what I mean?
Right.
Well, but we do tell them it's going to be super, super hard, but you know what? It's super, super worth it. You know, so.
Being that it's still the Detroit Auto Show, it's happening somewhere.
Yeah.
Well, let's go with this theme.
Okay.
You know, let's see if it works. I don't know. But we've been looking at the outside of the car, and it's pretty shiny, and looking at the rims like something GM maybe came up with. It looks snazzy. Now let's open the hood and look at the guts, like what's making this motor run. We have a nice, you know, a variety of different ways to do this. A hospital base, we have community treatment orgs, and we just have standing just a community service organization. I'd like to ask just, and I have a purpose of this, I have an agenda, but I just want to hear from each of you, how do you make this work? How do you sustain these efforts? I mean, you gave the arc of, kind of the fans development and what, these things that sprouted and there's a very healthy vine now that's growing. But how do you sustain that in your current efforts? And then we'll kind of move on from there. But yeah, would you like to start?
So at Families Against Narcotics, I think I wanted to touch on, and it'll take us to like this next point, but peer recovery coaches are the foundation of the work that we do at FAN, and we would not have been able to build this network without the peer recovery coaches that we have across the state. We are a statewide organization, which is really unique because we're able to help people across all of the PIHP systems access services, and we understand how to navigate those services. Why that's unique is many organizations are based on like their county restrictions and things like that, but Families Against Narcotics really started in McClelland County, and then other communities came to us and said, we want something like this in our community. And in the beginning, it was sustained by really hardworking volunteers that worked tirelessly to make sure that folks who are struggling with substance use disorder and their families had connection to resources. But throughout that time, we were able to go to the state of Michigan and really advocate for the work that we're doing. And currently, we receive funding through the state of Michigan to be able to do this work, which allows us to be able to serve the entire state. And really, that's we're tasked with that. We're tasked to make sure that we're partnering with different health systems and reaching across the counties to be able to fill in some of the gaps so that people across the state of Michigan have access to peer recovery coaching, to family coaching, and just basic connection to services. In addition to that, we are also actively engaging in being able to have grants in the community, and we do fundraising and things like that, but our largest funding source is through the state of Michigan, and we're really thankful and to be able to have that opportunity to carry on the work that we do and be able to continue to grow it year after year. I think another capacity thing to sort of talk you through how some of this works inside of the health systems is in Henry Ford, we talked about it a little bit, but we created this model that worked for their health system to dispatch peer recovery coaches. So the way that works is someone will come into the ER and they will say, they'll have like a quick assessment to figure out if this person, identifying if they're struggling with a substance use disorder. Once that has been identified, if the individual is going to be in the ER for 2 hours or less than 2 hours, then they will get connected to a peer recovery coach that will meet them in the community outside of the time when they're in the hospital. If someone's length of stay is going to be longer than 2 hours, then we'll dispatch a peer recovery coach to that health system, and they'll be able to meet with a peer recovery coach at their bedside if the person is well enough and really up to it. But the goal is that the folks that are coordinating those efforts inside the hospital to get them connected to the Hope Line, make that call, and then the Hope Line assigns them a peer recovery coach. We try and make this system as easy and low barrier as possible, so we really push that phone number where you're going to get linked to a real person. We also have an online form that people can fill out at any time and get linked to a peer recovery coach, typically within 24 hours if you're not calling from like a health system. But we really focus on like the urgency of this issue, and I think that's all of us have like this fire underneath our feet to make sure that folks have the resources that they need when they need it. So.
Okay, so a combination of, thank you for that. So your services are supported in combination from the state of Michigan investing in your work, as well as the collaborations and partnerships you've had. You've kind of gone after other opportunities to just support the work you do. Okay, so that's the model that you all are using. Is there, how do you pay for the services? How do the services supported, the ones that you all deliver?
I think the services are paid through the authority. Wayne County, and we make that call to the access, and people are actually given our opportunity to go to recovery based in their insurance, and so they take care of that through the access number, and we use what we call an expert screening tool to catch certain things that consumers don't say, and then we don't try to tell them that they addicted. We say based on this screening and the numbers, it shows that you may have a very serious problem that further treatment may be beneficial to you. You're starting to come into the hospital now. You're talking about liver damage, and so that tool helps them to see or become more educated and say, hey, maybe I do need some help. So the services are provided through Sobriety House. We have 20 hours of services in the ER Monday through Friday, and people can get that service. Also, doctors call us on the weekends too, and so we can do things over the phone on the weekend. If I have to go there, I will. If somebody is really ready to go, I will stop what I'm doing and go help them get into treatment. But how they will be paid for, I really don't get into how it's being paid for because the insurance, that's out of my league.
But there's a public support through the county. Is that the Behavioral Health Authority, or is that the
Health Authority?
Okay, so they give a block of.
Yeah, and they take care of all those financial logistics. And we have several different treatment centers that we can get people to. They tell us where they want to go. We don't try to promote our treatment center. And the good thing about it is because of the level of care, some people are not equipped to go to Sobriety House because they have stairs. You got to be able to be mobile. Some treatment centers are more health care than others. Everything is on the first level. So that's the good thing about the recovery support services and the treatment from the peers is we can actually look at the person's mobility and say which treatment center may be better suited for their level of care.
Kind of like a concierge service.
Yeah, but most likely we let them pick because they're more likely to do it if they pick their own opposed to us telling them.
Somebody mentioned this morning in one of the presentations about being involved with your local coalitions, and that is something that benefited New Paths. Not only did the PIHP support our peer recovery coach services and initiatives, especially in the hospitals, but we partnered and collaborated with Greater Flint Health Coalition in regards to advancing the medical model, to work with physicians in other medical settings as well. And also then it helped launch our quick response team, as Van was talking about, with the quick response teams in the local communities, that Genesee County has one as well. And because of our partnership with Greater Flint Health Coalition, we've been able to hire more peers, sustain those positions by showing outcomes. Your data tracking, they talked about IT support earlier and assistive technology. I mean, it's really important to track those outcomes and those successes. And when you're talking about the value, is what I see in treatment and recovery is that coaches bring the value of more successful outcomes in treatment. And being able to show that data and show those outcomes definitely helps bring those funds into your program.
So in addition to the PI, thank you for sharing that. That's a little bit different. But in addition to the PIHPs, you have reimbursement for those services. Sounds like you're doing a little bit of extra to support and sustain these services.
Yeah, and as they talked about earlier too, with the training, additional training too. A lot of our peer coaches are now doing the community health worker training. So it's also looking at those opportunities to continue to educate and train and develop your peer recovery coaches in those fields that relate and really coincide and work hand in hand with the work they're already doing. But if you can look at these other types of certifications and credentials that your peer coaches can get, that can also enhance the funding that's coming into your organization, whether it's community, hospital, or community treatment center based.
but it's an ongoing hustle. It's an
Oh, yes.
ongoing, effort. And how do you sustain and support these services? Obviously, you have partners.
Yeah, great question. A couple different ways I look at that, but one thing just to speak to the value of peer coaching, and especially when Frankee said, the truth telling, that kind of hit home because patients tell the peer coaches the truth. And, if you're really trying to take care of someone, I can think of several patient encounters where I walk away and I call my peer coach and I say, can you go find out what's really going on here? Because if I want to help this person, I need to know what is truly going on. And I think that patients are more forthcoming with peers, so that's just another value add. But the sustainability question is huge. I face that problem, especially at Henry Ford Detroit, the main campus. Obviously I'm using grant support. I would love for there to be some mechanism where we could directly bill insurance companies. I think that is one way. I think there could be a way I think we are creating external pressure on sustainability by the work we're doing with Community Foundation, and I also provide technical assistance to the hospitals in the state, and with Marissa and Emily and Sarah, and we are raising the level of care for SUD and OUD in the state, and so that breeds sustainability in itself. Now, as we continue to have these programs be viable at hospitals, at every hospital in the state, hopefully is the goal, that if you didn't have this, if you didn't have peer recovery, then what are you doing wrong? And I think we're elevating the level of care for these patients, and I think that's raising the standard of care. So I think that creates kind of pressure on hospital administrative resources to make sure we do have these things in place, and there's even examples of other states that have legislation that you have to have these kind of services in place. But lastly, and to kind of add to Erin's point about outcomes, so that's something I'm very interested in. My colleague, Dr. Miller, over there is a big researcher, and so I pick his brain pretty regularly on research, and we keep a database of every single patient that receives buprenorphine. I've gone back, and the ones that we've truly started on for the first time, we've got about a cohort of 130 patients that I have a year's worth of data after their presentation. We look before and after, and the patients are coming back to the ED less. Like 60% of the patients either come back to the ED 0 times or less the year before than they did the year prior. Hospitalization, 75% hospitalized less times or 0. And full disclosure, it's not statistically significant data yet, but we are presenting it at American College of Emergency Physicians meeting next month. So that alone speaks to the sustainability. If you're an insurer, HAP, in the case of Henry Ford, this should be standard. You're kind of shooting yourself in the foot by not providing these resources.
Well, thank you each for sharing that. I mean, if I'm taking away the message here, you all are doing it in a variety of ways to keep it going. So there doesn't seem we have a county authority, we have PIHP, we have state funding as well as other sort of pursuits, and kind of the ever challenging. You have a pot of money, you're getting this stuff going. How do you sustain it? This next question, and maybe our final, sort of in the last portion of our panel before we take some questions from the audience. What are some of the barriers or challenges you experience? It could be funding related, but it may also relate to stigma that you encounter, you may have, or your team may have encountered. It could be turnover, it could be supervision. But could you give us a sense of what some of these challenges are in doing this work? I'm just looking at you, but you don't have to be first on this.
Okay, I'll go first. I think one of the challenges for the peer recovery coaches is burnout. That's one of the biggest challenges, and really understanding as an organization how to address that, which we've done really, really well. We have a very open floor for our coaches to discuss. We have a meeting that I'm not even allowed to be in.
Coaching corner.
Yeah, we have our coaching corner, and we have our coffee and learn. So there's 2 a month where they can go and just vent about barriers and learn new ways to, maybe things that they're trying to accomplish with their participants that they don't have a resource for, or things like that. So I think that if coaches are not taking care of themselves and practicing self-care, burnout is a real thing. You get compassion fatigue, which I never heard until last year, but I'm like, oh, because you're trying to help people and you have this love and this drive to do it, and sometimes we do it more than, we don't put up healthy boundaries. But FAN has been fantastic. This organization is the best organization, honestly, that I've ever worked for, and I've worked in some pretty large, not SUD oriented, but very large companies that I was vice president of, and FAN is the most comfortable place to work. And I hear that from, I would say 95% of the coaches that work there, that they're just allowed to be themselves. And I think that, that removes some of those barriers. I think working with the community, a lot of our barriers are with PIHP systems, quite honestly. It's also stigma and getting people on board to helping individuals who suffer from SUD who maybe have never experienced doing that, right? Understanding that they are contributing to the community as a whole when you help one person, right? You're helping your children, you're helping your parents, you're helping this whole family who then has a family outside of that heal and become productive members of society. I'm working right now in collaboration with Recovery Friendly Workplace, and we're setting up this whole thing. And so that's one of the things that we're trying to do is get workplaces to be more recovery friendly and offer services outside of wine tasting and things like that for people who are in recovery, and making it an open door policy, which we have. But yeah, I think that the two main things for me that I'll just touch on, because there are many, and I'm sure Sandy can also, is burnout as far as the coach goes, and then working with systems who aren't designed to be, because a PIHP, right, their purpose is to help people get into treatment and provide outpatient services and those kind of things, right? Like, it's built under this model that when it's built had the right idea, but we're still depending on the people who work there. And if the people who work there aren't compassionate about what they do, and they stigmatize the people that are on the other end of that phone, they're less likely to ask for help.
I think one of the two major barriers for me is seeing people get off the ER truck dead. And you can never get used to that look. When they're coming down the hallway, you look the person in the eye, and there's no movement. You see them working, and they don't make it. And then another barrier is the fight between political insurance companies, political scene, where the person is in Detroit and his insurance is in Nepal. They can't get any services, but thanks to our director, she's able to fight through and get that person into treatment. And they got maybe 2 weeks to get the insurance changed, because Wayne County do the work and then the home still get paid for it. But the person suffers from that, Hope Not Handcuffed, Amnesty was Narcotics Anonymous. It's been a game changer for me, being able to call from Detroit and let them take over. It's been a huge game changer, because some of the zip codes for the transportation don't go all the way out to Telegraph Borough. You know what I mean? Or nobody. So with that, thank you for that service. That's just a great service.
Thank you.
Agency collaborating with different agencies to get the job done, because we can't do everything. So I thank you guys for that partnership. But other than that, getting some days off, like on the weekend, to keep me balanced. But being in the ER, you see it all, gunshots, heals from that, and then they call. And I seen a patient 3 weeks ago, they was stabbed, and now I'm seeing them, and then they want recovery. It's different dynamics. And then you see them in the treatment center, and they get that. I get to see the whole process, but I have to keep myself up. So I think, going to church and stuff like that helps me to stay balanced.
Would you add anything that your colleagues have shared here?
Everything they said is right on. I think the other thing that I would say from a administrative function is, I don't even know if this is the right word to use, but imposter programs, or individuals going in who claim to be doing the work that everyone up here on this panel says they're doing. Sometimes our coaches will come back and they're like, so-and-so is at the hospital and left this card, or they were meeting with somebody out in the community and they're trying to say they're a peer coach now, and it's like, whoa. So I just ask, respectively, if this is something obviously you're here because you're learning and you're educating yourselves, that you make sure the individuals coming into your facilities, whatever that looks like, are licensed and certified and supervised, and work for agencies who are providing those supervision services and are credentialed and, like I said, licensed, accredited. Because obviously, listening to all the hope and inspiration up here, who doesn't want to do this work, right? So everyone is kind of chomping at the bits, and everyone wants a piece, and then you hear the word opioid settlement dollars and funds, and it's like, oh, I want some of that, I want some of that. So, honestly, I mean, that would be advice that I would give you from an administrative standpoint, to really research and investigate and look into who's trying to come in and do the work in your facilities.
Yes.
Yeah, one thing that I think we can talk about a little bit more is the stigma that happens really in all systems. It happens in health systems. Patients may experience an uncomfortable situation with a doctor or a nurse or someone who really is just not understanding substance use disorder. One of the things that we do at FAN, and really one of the original things that we did out in the community, was going to share how substance use disorder impacts the family, breaking down some of the stigma, and some of the ways that we've done that is people sharing their stories and being able to share what their family experienced inside of a health system, or what they experience as a person struggling with substance use disorder. So we created this book called I'm Still a Person, and I brought a box today for all of you to take it, but it basically takes you through just a workbook on addressing the stigma of substance use disorder. There's actually a really neat story from our executive director, Judge Linda Davis, where she talks about her experience inside of the health systems with her loved one. And I think that this can just be really helpful, especially as a tangible tool for team members to be able to utilize and even look through. One of the things that we did with Henry Ford is we have these little packets that we create for them to hand off to their patients, and there's one of these in every single one of the packets. Just something for them to kill time. We experience self-stigma as family members or even as people struggling with substance use disorder, so this can be a really nice tool for anyone to grab.
Thank you all for coming and sharing your experience with your colleagues who are doing this work in a variety of respects. We just have a few minutes left. There's something we didn't explore as deeply, but hopefully someone's going to try and chew your ear off after, during a break or lunch to learn more about it. But each of you have had some degree of success working with a hospital system or working with a community organization. For those sort of hospital systems that are trying to do this or experiencing some of these same challenges you have, sustaining or initiating this stuff, in our last couple of minutes, is there any kind of word of wisdom or kind of a guidepost you can share if a hospital system would be interested in doing this? How would they establish these partnerships, or how would they go about, growing them?
Yeah, so I think first and foremost, find a champion, even just one, at your health system that's willing to champion something like this, that is willing to find other people, like-minded individuals, maybe folks that have experienced this in their own family. Those folks will do the work without even being compensated for it most times. And they'll do it because they care about that work. And so I think that was like the change that I've seen in many of the meetings that we've had is that health system was able to identify a person that was really passionate about this. And it wasn't just that we have to do this in our health system. It was this person, you know, found this very important to them, and they were able to sort of see it through. But I think the other thing too is you're welcome to reach out to us, and we're, you know, always bounce ideas off, really see what the capacity of your health system is, how we can help, and really what substance use disorder looks like in your community.
One thing I would like to add that I didn't really get to address, and this is like just bouncing off of what you said, like finding a champion, right? So like with Corewell, which is the one I'm most familiar with, so I don't mean to just talk about Corewell, but that's the system that I work with the most. But like their addiction doctor, Dr. Shamami, his team, he has a primary care office, and so what they do is Elena, who, and I don't want to discount Tiffany by any means, because she was, I think, our first champion over there, but Elena, partner, you know, got us together, and they refer people to us for peer recovery coaching services, right? Anyone who receives any kind of medically assisted treatment through that office. It could be anti-abuse, it could be, it doesn't necessarily have to be like buprenorphine or methadone or something like that. But they have a whole team collaborative, right? So they meet either every other week or once a month, and they make us a part of that team. And they all know so much about those patients. And then, you know, they talk to us and say, where are they? That, you know, being a part of that team. But if not for them understanding how important these services were, and having a champion, I don't know that would have happened, right? And they went out and they got grants and things like that to fund the peer coaching services, part of it to implement that. So I don't think without a champion it's possible, because it's not something that people are really passionate about. It's not even, coaching is not even a billable service right now through insurance, even though we do so much work in the community. And like she said, you know, Erin said, we've been getting our coaches certified as community health workers, because maybe that'll be a billable service soon, you know? So yeah, having someone, I mean, it's been imperative in what we do.
I would just say that as a, you know, piece of advice would be to find, you know, at least in Michigan, it's Community Foundation for Southeast Michigan. They're amazing group. They're really well organized, and they are really extremely well networked with both, not only the funders, but, you know, those of us that can provide some technical assistance, and that, along with what Dunya said about I would say even a physician champion, because you have to have your docs on board to do it. You know, my colleague from residency, Dr. Ford, is the kind of the poster child for being a motivated person from the doc side, and she's got Paul with her and her great team. So, you know, that's like a winning example right there. You have a motivated doc, because we have to speak doctor to each other, you know, and then having somebody like Community Foundation help connect the dots. I think that's the winning formula.
For us, it's Dr. King and Dr. Elrod. Their compassion for people in recovery is phenomenal. I mean, and they have gotten all the other doctors on board. Because if you don't know anything about DMC, it's a city of hospitals within the hospital. In the city, right? You got Hermanos, you got Bucks or Hustle, you got Children's, we don't go to Children's, but you got Hopper, and then you got Receiving. And this guy, Dr. King, man, let me tell you about him. He has other doctors texting me, and we never miss a patient from either hospital. And I think that's so phenomenal, because they type it in the chart, and upon discharge, maybe a week, 2 weeks later, that consumer gets a call from us, and we come see them, no matter where they're at in the hospital. And that's a game changer. You that's our champion. He don't like me to say anything. I appreciate it, you know.
Anything, Erin, quickly you'd like to share before we wrap?
They're shouting out their champions. I don't know if my mic broke or my God or not, but so I know Dr. Moderator was a big start to us when he was at Hurley, and then the West Side gravitated. But Dr. Reese and Dr. B over here for Hurley Medical Center have been huge champions and in buy-in for our program. And Lisa back there with Ascension, she works so closely with our ORP team in her position. So we're definitely, you got to have that buy-in in your health system. The champions are out here doing the work. We're doing it, UMass, BAN, or that university viewers. So we're doing the work. So get that buy-in in your health system and reach out to those who are doing the work, and we will partner. That is a no-brainer. But just getting that buy-in, the education, the knowledge. I think the most impactful thing, and I think that Ann shared it earlier, is when we can bring the coaches in to share their personal stories. Same for when we do it with law enforcement, medical teams, medical offices. It's like, oh, the work you do, there are outcomes, there are rewards. People do succeed. It isn't always just the bags. I know in the ED, that's all you see. Stab wounds, shootings, burns, whatever it may be, overdose, alcohol intoxication, seizures, any other medical disorder. But when you get to see the outcomes, you get to see the person standing in front of you and they're like, you helped me 7 years ago, or you helped me 30 days ago, or whatever it may be, that's the impactful part too. So we have lots of people who can come and share their stories with you if that's the kind of buy-in that you need.
Thank you to everyone for sharing your experience. I think, will you yank us off, or is there off the stage, or we have questions? We have a few minutes still for questions? Okay, great. So if anyone has, please feel free.
Do we have any questions?
We're just preaching to the choir here.
I guess I didn't realize, or maybe I never thought about it enough to realize, well, that it's not a billable service. So I guess I'm just wondering, like, next steps, and if you have any advice to, like, regular champions like me, like, actually, recovery coaches kind of remind me of doulas, you know, in the birth space. And I know they were successful at getting certified and are now billing for their services at the state level. So I just wonder if there's any way to support that, or a listserv to get on, as far as if there's any movement towards, I know you said you're getting certified as community health workers, but is that the answer, or is the answer just getting the state to pay for it without that level, without a level of licensure certification? Or if there's any suggestions you could give for advocacy on that, I'd be happy to hear it. And maybe that there's
The
not.
only thing I can really speak on, and they may be better qualified to answer this question, is if you're connected with, I don't want to say all PIHPs, if you're not connected with the PIHP that we are affiliated with in McClelland County, they do pay for coaches, right? They do have programs that pay for coaches. But if you're not contracted with them, you don't get any of that money, right? So you can't bill Medicaid. It is a billable service through Medicaid, right? But if you're not contracted with your PIHP, you are not a billable. And in our area, we have the largest coaching program, but we are not contracted with our PIHP, so we do not see any of those dollars. And it's kind of strange because one of the major certifications in the state of Michigan is through MDHHS, right? They certify peer recovery coaches. They train, test, and certify them. So that's you know, the bottling part to the coaches. But people who handle the administrative end of it may have a different answer, because that part of it I just don't understand at all.
Yeah, I was going to say Linda might be able to answer this a little bit better.
Linda, you'll probably know the answer to this. So my follow-up question is, someone from a PIHP, what exactly can the peer recovery coach get reimbursed for? What are the services that are reimbursable?
Yeah, I can answer some of that.
Hi, Branislava Arsenova, NMRE PHP Region 2. H0038 would be a reversible code if you are paneled with your PHP. To be able to be paneled with PHP, you have to meet a ton of requirements and then be audited on those requirements. So I believe that's probably what's preventing you from billing those services. There are also codes that can be utilized for peer recovery supports. So that's everyone who's not certified to provide peer recovery, CCAR or MDHHS. So those who do not have CCAR and MDHHS certification, they would be able to bill T1012. Code for peer support, T1012. I can slow down. But for those services, you would also have to be paneled with local PHP or multiple PHPs as well, considering the area that you cover. So a lot of services can actually be provided. However, there is some modification as to are you providing that in community. Community is not necessarily always covered, but is something that is being looked into. Recently, in May, with PHE ending, there was a huge issue with MDHHS actually preventing H0038 to be provided audio and video. It had to be face-to-face only, in person, that is. And your subdirectors provided a lot of support and advocacy to MDHHS, and that was reversed. It is not allowed to be utilized audio only at this time, but we're working on that. So there is more and more flexibility to those codes to be utilized. And if you have any questions about that or need more advocacy, just let me know. Region 2 again, I'd love to do that. But there are some options out there.
Thank you, and I'm so grateful that we have a PHP here too. You know, sometimes it's difficult when you have a different purpose in a system. I think the challenge, and the Health Endowment Fund is partnered with SAMHSA, where half of my projects and time are dedicated to the Substance Abuse and Mental Health Services Administration. I can tell you we got a call at our regional level asking us, so regional CMS, Medicaid and Medicare services, your Michigan Health and Hospital Association, who's here, regional SAMHSA, headquarters SAMHSA, headquarters CMS, are debating this issue right now. In some of the recovery communities where you have peers, they really don't want Medicaid because it's hard to do all the aspects of harm reduction with peers, right? With some of the certifications that are critical in the health and hospital situation, and we heard about that with peers. And there's also so I think we have a good path with the health systems and with the treatment systems. I think this panel here has proven we can go there, we can expand, the PHPs can do part of it. Forward thinkers like Dr. Beecroft and other health plans who aren't represented here today, forward thinkers like that, what they really need is a proof of concept, right? And some evidence so that you can sell it, for more health plans to step up and say, Dr. Beecroft said it well today, 5% of the cost of this is behavioral health, 95% is medical. If we can make a case where you can save 2% on that medical cost, or 1% or something, there's a new case here to be made to health plans, private and public, that I think we're missing out on a little bit. But the PHPs can go a long way, but they can't go everywhere. Yep, oh, there's one more thing she wants to add, and then I think we need to go to somebody else.
So speaking of PHP and limitations of PHP funding, I feel like all know about that. But there's this beautiful thing that is called PA2, also known as liquor tax, that if available, go for it. Those are services that cannot be funded in different fashion. So if standard Medicaid, Medicare, other insurance does not cover services, your counties have liquor tax funds that could be utilized for these projects.
And that's through a PHP.
That is, PHP is a pass-through. Go ahead. Yay, for Detroit Way. Okay, perfect. That's good to know. But spread the word, and don't tell anyone I told you.
Sorry, our table has taken over.
Sorry, we have taken over. And please forgive me because I think I'm going to mess up your name. Dr. Manteuffel? Okay, I messed it up.
Yeah.
But anyway, you talked about earlier that Henry Ford is in the beginning stages of evaluating the the cost savings in the ER. Who's supporting that evaluation effort?
No one?
No one? Okay. So, okay. Because I agree with Linda that to the point that you can make that cost savings case, that'll really help make it sustainable in hospital systems.
This is a second iteration of this review. You know, we just started our program in March 2020, which was like a great time to start programs. So I have, you know, in theory, I could have outcomes data through all my patients that we've administered through, you know, as of today, 2022, because I'm looking for a year of outcomes data afterwards. So it's limited, but I'm up to, you know, 130 patients now in the last data review, and you know, the first iteration had 30, and it showed the exact same stats, but it wasn't statistically significant. In this next round, the p-value's down to 0.09 for the stats nerds out there, so it's getting closer to 0.05, and that's when, you know, like I said, I think it just makes a financial case alone, and, you know, as much value as I know peer coaches bring, they're not, you know, extremely expensive, even though they deserve to be paid double and triple what they make. But you know, so to me, the financial case is, you know, it's like tripping over you know, dimes to pick up, or you know, tripping over dollars to pick up dimes.
I would just add something just on the issue of reimbursement. A lot of times, like this would be a great solution to sustain this, but you know, I'm based in Pennsylvania and I'm familiar with its Medicaid system, and it's like Michigan, is carve out behavioral health and physical health. A lot of the physical health providers are not engaging with your PIHP because they're kind of you know, separated, except for the medication actual costs. But even in these, and I've worked with organizations who were early on, who had certified recovery specialists, they actually get reimbursement for a 15-minute unit. They're doing this great work, and they can't meet their costs because the rates, but there's things you can't bill for, like the traveling to, like if you're deploying the peer. I mean, when do you start the billing? You're gonna get audited and all these things. So, you know, as like one solution there is just one of those like little dimensions of it that's like, ugh, you know, didn't quite get it, but I think we're getting close to it.